Welcome to the deep dive, everybody. I know you're out there listening right now. You are the learner.
The one who's always looking for that edge.
Exactly. That deeper, more profound understanding of what you're actually doing. And today, we are bringing you something that is incredibly high stakes. We are unpacking a stack of your specific study materials.
Your syllabi, your clinical notes.
Right, for CNUR 302. Pediatric medication math.
It's a heavy topic.
It really is. Now, I want to set the scene for you right out of the gate. This is not just another casual study session. We aren't here just to help you memorize a few abstract formulas.
So you can pass a piece of paper and then immediately forget everything the next day.
Right, exactly. This deep dive is about peering into the hidden, highly precise, almost invisible mathematical safety net.
The net that protects the absolute most vulnerable patients in our entire healthcare system.
Children.
Yes.
Children.
We're going to master the exacting, uncompromising precision required in pediatric nursing. Because in this field, a single misplaced decimal point, literally, just a tiny dot of ink on a page, or a stray pixel on a computer screen.
Yeah, that can quite literally be a matter of life and death.
That is exactly the right framing for this material. It's a pleasure to be here to walk through it.
Glad to have you.
When we look at the documents and the course outline you've provided for this deep dive, the central overriding theme that jumps out immediately is a biological reality.
Which is?
Children are not just miniature adults.
Right. You can't just take an adult dose of a medication and, chop it in half because the patient is half the size.
Exactly. Their biology, their metabolism, the way their liver enzymes function, their entire physiological processing system is fundamentally structurally different.
Wow.
And because of that biological reality, the mathematical rigor required to safely administer any chemical to them is completely uncompromising. There is zero room for guesswork.
Zero. I want to keep that weight, that seriousness in mind as we go. But before we get into the heavy math, before we look at the life and death scenarios and the pharmacology, I want to ground this deep dive in your immediate physical reality as a student. Let's talk about the mission at hand.
The exam.
The massive exam you have coming up. The date is Thursday, March 5th, 2026.
Put it in your calendars if you haven't already.
Seriously, the time is exactly 0900 to 1000 hours. You need to physically be in Parkway campus, room 229. So right now, wherever you're listening to this, visualize yourself walking through those doors, finding your desk, and sitting down in room 229.
It's an in-person exam.
Very much in person. Right after the exam finishes at 1000, you only get a brief 30-minute pause.
And then lecture number 2 starts right up at 10:30.
It's a gauntlet. You're going to be facing exactly 30 questions. And here is a crucial, intimidating detail from your syllabus. There are no short answer questions.
No partial credit for writing down your feelings about the math.
Yeah, none of that. It is going to comprehensively test both your skills lab content and your raw medication calculations. Now, what can you actually bring with you to your desk? Blank paper and a basic calculator.
That is it.
No phones, absolutely no graphing calculators. You're going to rely entirely on your basic math skills and the foundational knowledge we're about to build together right now.
And that restriction on the type of calculator is highly intentional by your instructors.
Really? It's not just to stop cheating.
I mean, that's part of it, but it might seem punitive. But in clinical practice, on a busy pediatric ward, you will not always have access to a sophisticated graphing device.
That makes sense.
Furthermore, pulling out your personal smartphone to do math is often strictly against unit policy for infection control.
Oh, because phones are famously covered in bacteria.
Exactly, and for patient privacy reasons.
Yeah.
You need to be able to execute these calculations with the simplest, most primitive tools available. The goal is to ensure that the logic of the math is deeply internalized in your own mind, not outsourced to a microchip.
That's a great point.
What is fascinating here is how the course material explicitly compares pediatric medication to adult medication right off the bat to shock you into paying attention.
Yeah, the text states point blank, giving medications to infants and children is not the same as administering medications to adults.
The two words they use over and over, bolded and underlined, are precision and accuracy.
Precision and accuracy. I see those words everywhere in these notes. And they follow up that demand for precision with a really specific, almost theatrical protocol. To guarantee that accuracy, the material mandates something called a blind check, or an independent check with another registered nurse, or RN.
A critical protocol.
Now, I'm reading this and thinking, what does a blind check actually look like on the floor? Because my mind immediately goes to someone putting on a literal blindfold.
Which I'm guessing is absolutely not the case.
Right. Why call it blind?
It's a great question, and understanding the psychology behind it is a fundamental safety mechanism. A blind, independent check means that you and your colleague perform the exact same medication calculation completely separately, without looking at each other's work, without looking at each other's calculators, and most importantly, without knowing what final number the other person arrived at beforehand.
Oh, I see.
Think about human nature. If I walk up to you at the nurse's station and say, hey, I just calculated 2.5 milliliters of morphine for this child in bed 4. Does that look right to you?
I'm probably just going to say yes.
Exactly. I've already hopelessly biased your thinking.
Yeah.
Human nature, especially when we are busy or tired, is to defer to a colleague and agree. Your brain will unconsciously try to make the math equal 2.5 to avoid conflict or save time.
Oh, wow. So you are anchoring their expectations before they even look at the patient's chart.
Yes. You've ruined the independent nature of the check. Instead, to do a true blind check, I hand you the original doctor's order, I hand you the patient's current weight, and I hand you the physical bottle of medication with its concentration.
Just the raw materials.
Just the raw materials. And I simply say, please calculate the dose for this patient. I do not give you my number. You sit down, pull out your calculator, and do the math completely from scratch.
And then?
Then, and only then, do we turn our papers around and compare our final numbers. If my number and your number match perfectly, down to the decimal, we proceed.
What if they don't?
If there is even a fraction of a discrepancy, if I have 2.5 and you have 2.05, we do not just split the difference.
That would be bad.
We stop everything, we reevaluate, we pull out the reference books, and we absolutely do not administer that drug until we figure out who made the error. That is how you prevent catastrophic, irreversible errors in a hospital setting.
Okay, let's unpack this. Because to even begin doing those calculations, whether alone or with a colleague, we need to understand exactly who it is we are treating. We are moving into the foundational rules of pediatric pharmacology.
Right.
Let's look at the basic building blocks, starting with the patient themselves.
The ages and stages.
Exactly. I was looking through your source material, and I am genuinely marveling at how specific and rigid the pediatric age categories are. In everyday life, we just say babies, toddlers, and kids. But here, the timeline is incredibly strict.
It's a whole different language.
It feels like it. Looking at the syllabus, why is the terminology so formalized, and what are the exact cutoffs?
In the context of pediatric care, terminology is formalized because different age brackets have wildly different physiological capabilities. According to your CNUR 302 materials, here is how the ages are strictly legally categorized for the purpose of dosing.
Okay, lay it on me.
First, we have the neonate. A neonate is defined as a patient who is less than 28 days old.
Less than 28 days.
The moment they hit that 28-day mark, the terminology shifts entirely. From 28 days old up to 1 year of age, the patient is classified as an infant.
Infant up to 1 year, got it.
Then, from exactly 1 year of age up to 12 years of age, they are officially a child. Finally, from 12 years of age up to 18 years of age, they are categorized as an adolescent.
I want to pause right there because that first distinction is wild to me. So if you are treating a patient who is 27 days old, you chart them as a neonate.
Correct.
If the patient in the next bed is 29 days old, you chart them as an infant. To an outsider, or even a new nursing student, that might seem like aggressively splitting hairs. Why does a matter of 48 hours change the entire medical and pharmacological classification of a human being?
If we connect this to the bigger picture of human biological development, those early days are a period of massive, almost violent physiological change.
Violent change.
Yes. A 20-day-old neonate processes chemicals, metabolizes proteins, and filters toxins in a vastly different manner than a 6-month-old infant, let alone a 3-year-old child. Let's look at the liver.
Okay.
In a neonate, the liver is incredibly immature. The specific enzymes required to break down complex medications simply do not exist yet in sufficient quantities. Furthermore, look at the kidneys.
This is filtering differently.
Their glomerular filtration rate, how fast their kidneys can clear waste or drugs from the blood into the urine, is a fraction of an older infant's. Even their blood-brain barrier is more porous.
Meaning drugs that wouldn't normally affect the brain in an older child can slip right into a neonate's brain tissue.
Precisely. The pharmacological data reflects all of these shifting variables. A dose of an antibiotic that is perfectly safe and necessary for a 40-day-old infant could be deeply toxic, perhaps even fatal to a 15-day-old neonate.
Purely because they can't clear it.
Exactly. Purely because the neonate's body cannot clear the drug from its system fast enough. It builds up to toxic levels. These rigid categories aren't just bureaucracy. They force the nurse to pause, look at the calendar, and consciously recognize the exact biological stage of the developing human in front of them before doing a single piece of math.
That context makes it so much more than just a vocabulary test. And speaking of forcing you to pause, we have to talk about the rounding rules.
The rounding rules are crucial.
I will admit, looking at this part of the syllabus, I felt slightly intimidated. In standard math, the kind we all learn in middle school, rounding is easy. You round up if the number is 5 or more, and you round down if it's 4 or less.
But here, the rule entirely depends on the physical volume of the liquid you are holding in your hand.
Help me understand these exact guidelines, because I know they will be heavily tested on March 5th.
The rounding rules are an absolute cornerstone of this exam and of your future clinical practice. The entire premise is based on the size of the syringe you are using.
The physical syringe.
Yes. The first rule addresses very small volumes, amounts of liquid that are less than 1 single milliliter. If your final calculated amount, after all your math, is less than 1 LL, your course material dictates that you must round your answer to the 100th decimal place.
Okay, let me visualize that. The 100th place means 2 spots after the decimal point.
Correct.
The example they give in the material is a long calculation that results in the number 0.324. So because 0.324 is less than 1 whole milliliter, we look at the third decimal place.
Which is a 4.
Right. Because 4 is less than 5, we round down. So the final official answer you write down on your exam paper or in the patient's chart is 0.32 ml.
Exactly. You preserve 2 decimal places. Now, the second rule applies to larger volumes. If the calculated amount is greater than 1 milliliter, the rule changes.
To what?
You round to the 10th decimal place. That is just 1 single spot after the decimal point.
Let's use the course example here.
It's a calculation resulting in 1.893. Because 1.893 is greater than 1, we only want 1 decimal place in our final answer. We look at the second decimal, which is a 9. That 9 dictates that we round the 8 up to a 9. The final answer becomes 1.9 millil.
I'm trying to wrap my head around why the rule changes. Is it just because smaller volumes require more granular precision?
Yeah.
Like a tiny variation in a tiny dose is a huge percentage difference, whereas a tiny variation in a large dose is a drop in the bucket.
That is part of the mathematical logic, yes. But the clinical logic is tied to the physical equipment you will use in the hospital.
Oh, the syringes again.
Right. If you have a dose of 0.32 mmol, you will draw that up using a specialized 1 LL syringe, often called a tuberculin syringe. That specific syringe has physical lines printed on the plastic barrel marking every single 100th of a milliliter. You can physically accurately draw up 0.32.
With the larger dose.
However, if your dose is 1.9 millimol, you will use a larger 3 millil syringe. A 3 millil syringe only has physical markings for every 10th of a milliliter. It is physically impossible for a human being to accurately draw up 1.89 millibel in a 3 millil syringe.
You're just guessing between the lines.
Exactly. So we round to 1.9 millimel, which has a distinct physical line you can measure against. The math reflects the physical tools.
The math reflects the physical tools. That's a brilliant way to remember it. If I'm holding a tiny syringe, I need 2 decimal places. If I'm holding a standard syringe, I need 1. But then we get to an absolute strict prohibition in the material. It is a rule that seems to exist purely to punish students.
Ah, the trailing 0.
Yes. The trailing 0. The text literally bolds the instruction, do not use trailing zeros. They give the example of writing 0.250 milligrams. That is strictly forbidden.
Highly forbidden.
I have to push back on this. Mathematically, 0.25 and 0.250 are identical. They represent the exact same value. Am I really going to fail an exam question or get a severe reprimand on the floor over a 0 that changes nothing about the actual amount of the drug? It feels like a bureaucratic technicality.
I completely understand why it feels like a technicality when you're sitting in a well-lit classroom looking at a pristine white piece of paper. This raises an important point about how medical errors actually happen in the real, chaotic world.
Okay, set the scene for me.
Mathematically, you are perfectly correct. The 0 changes nothing. However, nursing does not happen in a sterile, perfectly calm mathematics laboratory. Let me paint a picture for you of why this rule exists.
Right.
Imagine it is 3:00 a.m. on a pediatric ward. You are on the 10th hour of a 12-hour shift.
Exhausted, in other words.
Beyond exhausted. The lights are dim to let the children sleep, except for the harsh fluorescent glow of the computer monitor. You are reading hastily written orders from an exhausted resident, or glancing at a poorly printed label on a medication bag. If you or a doctor write .250 and that tiny decimal point is faint, or there is a smudge on the paper, or your tired eyes simply skip over it as you are rushing to stabilize a crying infant, what does that number suddenly look like?
If I miss the decimal,
Mhm.
0.250, it looks like 250, 250.
Exactly. Now consider the scale of that error. Instead of administering a quarter of a milligram of a potent drug, you are suddenly drawing up 250 milligrams. That is a 1,000-fold increase. You are giving 1,000 times the intended dose.
That is terrifying. That is not just a mistake that is instantly fatal for almost any drug.
It is a guaranteed fatality. A trailing zero provides absolutely zero additional clinical value. It does not make the math more precise, but it introduces an exponential catastrophic risk of a massive overdose purely through optical illusion.
An optical illusion.
Yeah. That is why your instructors, the hospital administration, and the healthcare system at large treat a trailing zero not as a simple typo, but as a critical, fireable safety violation. On your March 5th exam, if you write a trailing zero, expect to be penalized heavily, and in a real clinical skills test, it is an automatic failure.
I am writing that down right now and underlining it 3 times. Do not use trailing zeros. The risk is just not worth it. And this concept of how things physically look on a page brings us right into the grammar of healthcare. The abbreviations.
It's practically a second language.
You and I both know the medical field loves an abbreviation, but they are incredibly rigidly picky about which ones are correct versus which ones are completely forbidden. Let's look at the correct versus not correct abbreviations from your text. For grams, the only correct abbreviation is a single lowercase g. The syllabus explicitly states you absolutely cannot write G, GR, or GMs. Why? The policing of letters.
Once again, every one of these rules is written in the blood of past errors. Let's look at Jim. If a doctor writes Jim quickly in cursive handwriting, the loops of the Jim can easily bleed together and look exactly like an MG.
Suddenly, grams become milligrams.
Or vice versa, resulting in a 1,000-fold dosing error. And Drin is even worse. Drin stands for grains, which is a deeply antiquated apothecary unit of measurement that is entirely different from grams. 1 grain is about 65 milligrams.
So if you mean grams and write Gino, another nurse might calculate the dose in grains. It is chaos.
Total chaos. If you mean grams, you write the letter G, period.
Okay, moving down the list. For milliliters, the correct abbreviation is a lowercase m followed by a capital L, so ml. You cannot write a lowercase m, and you cannot write a plural mLs. For milligrams, it's a lowercase m, not a lowercase m with a capital G. And for micrograms, this is a big one, the accepted abbreviation is MZ.
That's a very important one.
You cannot use the Greek letter mu followed by a G, which looks like a lowercase u with a long tail on the left side. I've seen that Greek letter in physics and chemistry classes all the time. Why is it banned in nursing?
The Greek letter mu, written as G, is notoriously, historically dangerous. When handwritten by a doctor in a rush, the long tail of the mu is often shortened or looped poorly, and it looks absolutely identical to an M.
So G looks exactly like mem for milligrams.
Remember, a microgram is 1/1000th of a milligram. If a doctor orders 50 micrograms of fentanyl and writes it with the mu symbol, and a nurse misreads it as 50 milligrams of fentanyl, they will administer 1,000 times the lethal dose of a potent narcotic. Hence, the letters MCG are the only legally accepted standard in modern pharmacology charting.
Makes total sense.
Furthermore, as the text explicitly states, abbreviations should never ever be pluralized. You don't write 5 kilograms or 10 millis, you write 5 kilograms and 10 milligrams.
Because adding an S just adds clutter.
Clutter and potential confusion. A rushed S can look like a number 5. So 10 milliliters might be misread as 10 milliliters 5. It strips away any possibility of misinterpretation. Keep it clean, keep it singular.
It really is all about stripping away the friction of communication. Along those lines, they also ban common mathematical symbols. You cannot use the symbols for less than or greater than, you know, the little alligator mouths we all learned in elementary school math.
Right, no alligator.
You have to physically write out the full English words less than and greater than. And you cannot use a forward slash like the symbol on a keyboard to mean the word per. You have to write the 3-letter word PER.
What's fascinating here is the specific practical distinction your instructors make for your exam and for your future charting.
Huh.
The material notes that in the real world, a doctor's printed order or a commercially printed medication label from a pharmaceutical company might still read NGML with the slash.
So you will see it.
You cannot control what the pharmacy prints. You need to be familiar with reading it. But when it comes to your own legal charting, and crucially, for your final written answers on this medication math exam, you must write it out as mg per ml. Do not use the slash on your test paper.
So if you are sitting at that desk in room 229 and you have done a massive complex calculation perfectly and you arrive at the correct number of 10, but you write 10 milligml with a slash, you might lose points. It has to be 10 milligram per ml. Got it. Before we leave this foundational section, let's quickly review the golden rules of conversion they want you to memorize natively.
The conversions are your bread and butter.
The material states 1 gram equals 1,000 milligrams. It also states 1 gram equals 1 millimeter conversion. And finally, 1 kilogram equals 2.2 pounds.
Just to provide a touch of clinical context on that 1 gram equals 1 milliliter conversion, because it trips some people up. In strict physics, that 1.1 ratio is only perfectly true for pure distilled water at a specific standard temperature and pressure.
Right, I remember that from science class.
But in nursing math, especially in pediatrics, when we are calculating fluid volumes, or more commonly, weighing a baby's wet diaper to calculate their exact urine output, we use this 1 gram to 1 milliliter ratio as the universal standard operating metric.
If a dry diaper weighs 20 grams and the wet diaper weighs 50 grams, the difference is 30 grams.
Using our rule, we chart that the baby produced 30 milliliters of urine, and the kilogram to pound conversion is vital because in North America, parents will almost always report their child's weight to you in pounds. Oh, he weighs 20 pounds.
But every single piece of pediatric safe dosing math is strictly, exclusively calculated in kilograms.
You must always mathematically convert the weight first before touching the medication.
Okay, we have our building blocks securely in place. We have our neonate and infant ages, our rounding rules based on syringe size, our band abbreviations and trailing zeros, and our basic conversions. Now, we are stepping into Section 2 of our deep dive, the Lexicomp standard and the safe dosing formula. I noticed a very specific, strongly worded instruction right at the beginning of the PowerPoint notes provided in your syllabus.
Let me guess about Nursing Central.
Exactly. It says, Nursing Central is not the best pediatric reference. For PEDS, we will use Lexicomp exclusively. What is Nursing Central, and why is it being tossed out the window here?
Nursing Central is a very popular, widely used, broad-spectrum digital reference tool. Many nurses rely on it daily for adult patients. It gives great overviews of diseases, drugs, and standard adult dosages. But as we established in our very first point today, children are not just small adults.
So the adult database fails them.
Standard adult databases, like Nursing Central, often fail pediatric patients because they lack the deeply granular, microspecific, weight-based and age-based dosage ranges required for pediatric safety. You cannot just look up amoxicillin in a general database and give it to a 2-month-old.
And Lexicomp is better.
Lexicomp is considered the absolute gold standard in pediatric pharmacology. It provides incredibly precise, heavily researched, evidence-based dosing guidelines that are specifically tailored and separated out for neonates, infants, children, and adolescents.
And the material even tells you exactly how to access it, which is great practical advice for your study sessions. You go to the Sask Polytech Library website, click on Digital Resources, and find the link for up-to-date Lexidrug. The implication is that you will be living in that database for the rest of your pediatric career.
You absolutely will be.
So let's look at a real-world scenario straight from the text to see exactly how we use Lexicomp to build a mathematical safety net. We have a clindamycin example. Let me set the clinical scene for you. The patient is a term infant, meaning they were not born premature. We put them on the scale and they weigh exactly 9.3 kilograms.
9.3 kilos.
The condition being treated is a susceptible infection, meaning a bacterial infection that lab tests show will respond to this drug. The doctor's order is written in the chart as clindamycin 65 milligram PO88. Let's translate the abbreviations first. PO means per os, or by mouth, and catate means every 8 hours.
Standard order.
The physical medication available to you in the unit's supply room is a bottle of liquid concentration of clindamycin that reads 150 milligrams per ml.
So as the nurse, before you even think about touching that bottle or drawing up liquid, you must perform your Lexicomp investigation. You open the database, search for the drug clindamycin, and look specifically under the heading Dosing, Pediatric.
Yeah.
You then find the subheading for general dosing, susceptible infection.
And what does it say?
According to the exact lexicon excerpt provided in your course material for an oral route, the safe dosing range is listed as 10 to 25 millikilo a day divided every 8 hours.
All right, I have my basic calculator ready. But honestly, looking at all those numbers, the baby's weight, the doctor's dose, the bottle's concentration, and the lexicon range, it feels like a massive jumble. Walk me through this math step by step, really slowly, as if I'm looking at the calculator screen. How do I build this safety net?
We take it one logical step at a time. Do not look at the doctor's order yet. Our very first goal is to build our own mathematical boundaries, our floor and our ceiling, for this specific 9.3 kilogram infant based on the lexicon data. We always start with the minimum per day, the floor.
Okay, the floor.
Lexicon says the absolute minimum dose is 10 milligrams for every kilogram of body weight per day. So type 10 into your calculator. Now multiply that by our infant-specific weight, which is 9.3 kilograms.
Okay, 10 times 9.3, that gives us exactly 93. So 93 milligrams.
Precisely. That 93 milligrams is the minimum amount of this drug the child needs in a whole 24-hour period to actually fight off the infection. That is a subtherapeutic floor.
So if we give less than 93 milligrams over a whole day, the bacteria will likely survive, multiply, and the child will get sicker.
Exactly. Now we calculate the ceiling, the absolute maximum safe dose per day. Lexicomp states the high end of the range is 25 milligrams per kilogram per day. So type 25 into your calculator and multiply it by the 9.3 kilogram weight.
25 times 9.3 equals 232.5, so 232.5 milligrams.
Excellent. We have now built our safety net. Our total safe daily range for this specific infant is anywhere from a minimum of 93 milligrams up to a maximum of 232.5 milligrams per day. If a daily order falls outside those numbers in either direction, it is unsafe.
Okay, we have our boundaries locked in, 93 to 232.5. Now we finally look at what the doctor actually ordered and see if their math fits inside our net. The doctor ordered 65 milligrams to be given every 8 hours. To find out the total amount the doctor wants to give for the whole day, we need to figure out how many doses that represents.
Right, because it's every 8 hours.
A full day has 24 hours. If we're told to give it every 8 hours, we divide 24 by 8, which equals 3. So the child is getting exactly 3 distinct doses in the 24-hour period. Each single dose is 65 milligrams. So 65 milligrams multiplied by 3 doses equals a total of 195 milligrams per day.
And this is the moment of critical thinking where the nurse either proceeds or stops the line. You compare the doctor's total daily intended dose of 195 milligrams to your independently calculated safe range of 93 milligrams to 232.5 milligrams. Ask yourself, does the number 195 fall safely between 93 and 232.5?
Because it does. It is safely above the minimum floor and it is safely below the maximum ceiling. Therefore, you can legally and confidently conclude that the physician's order is safe to administer. Exactly. Phew. The doctor did their math right.
Mm-hmm.
But my job as the nurse isn't done. I've determined the order is theoretically safe, but I still have a physical bottle of liquid in my hand that says 150 milligrams per ml, and I need to draw up exactly 65 milligrams for this single dose. I can't measure milligrams in a syringe. I can only measure milliliters. How do we figure out the physical liquid volume to draw up?
To convert the ordered dose into a physical liquid volume, we use the standard universal nursing formula. The dose ordered divided by the dose available multiplied by the volume the available dose comes in, often remembered as desired over half times volume.
Let's plug in the numbers. The dose ordered by the doctor for this single administration is 65 milligrams. The dose available in the concentration of the bottle is 150 milligrams.
Yes.
Okay, calculator out. I take the desired 65 and I divide it by the 150 we have. That gives me a long decimal, 0.43333 repeating. I multiply that by the vehicle volume, which is 1 milliliter. So my raw, unrounded mathematical answer is 0.433 milliliters.
And here is where we must immediately recall and apply those foundational rules we discussed in Section 1. Your raw answer is 0.433 LLO. Ask yourself, is this volume less than 1 milliliter or greater than 1 milliliter?
It is clearly less than 1.
Do you remember the rule for volumes under 1 LL? We must round to the 100th decimal place, which means we preserve 2 decimal places. We look at the third decimal number, which is a 3. Because 3 is less than 5, we round down, leaving the second decimal unchanged. Your final, perfect, exam-ready answer to write on the paper is exactly 0.43 LL.
That is incredibly satisfying. Building the boundaries, checking the order, calculating the liquid, applying the rounding rule. That is how it is done when everything goes perfectly. But what happens when the doctor gets it wrong? That brings us to Section 3 of our outline, Catching Errors. Because, let's be honest, doctors are human beings.
They are very much human.
They're working long shifts, they're covering dozens of patients, and sometimes they make mathematical or transcription errors. The nurse is the final, ultimate barrier between a mistake on a chart and a mistake entering a patient's bloodstream. We have three specific, highly instructive scenarios from the text where the nurse has to catch an error. Let's look at scenario 1, the subtherapeutic trap.
This is a critical scenario to study because human psychology often makes us miss it. Usually in healthcare, we are so hyper-focused on preventing toxic overdoses that we forget the profound, insidious dangers of underdosing.
Underdosing can be just as bad.
Absolutely. In this clinical example, we have a 9-year-old child who weighs exactly 25 kilograms. They have been diagnosed with a urinary tract infection, or UTI. The doctor's order reads Septra 75 milligram IV Q12 hour, meaning 75 milligrams of the antibiotic Septra delivered intravenously every 12 hours.
Okay, I know the drill now. I don't look at the doctor's 75 milligrams yet. I do my Lexicomp investigation to build my safety net. For treating a UTI using IV Septra in children, Lexicomp states the safe range is 8 to 10 milligram colligaday in divided doses every 6 to 12 hours. Let's break down the safe daily range first, starting with the floor. The minimum is 8 milligrams per kilogram. So 8 milligrams multiplied by the child's weight of 25 kilograms equals 200 milligrams per day.
That's your floor.
The maximum ceiling is 10 milligrams per kilogram. So 10 milligrams multiplied by 25 kilograms equals 250 milligrams per day. Our safe daily window is incredibly tight, 200 milligrams to 250 milligrams per day.
We have our net. Now, let's evaluate the doctor's order. The order is 75 milligrams to be given every 12 hours. In a 24-hour day, giving a drug every 12 hours means providing exactly 2 separate doses. So we multiply the single order dose of 75 milligrams by the 2 doses. 75 multiplied by 2 is 150 milligrams per day.
And there is the glaring aha moment. The math fails. The doctor has ordered a total of 150 milligrams for the entire day. But our absolute minimum safe dose, the biological floor required to actually kill the bacteria causing this child's UTI, is 200 milligrams. The doctor's order of 150 milligrams is entirely below the minimum floor.
Which raises an important question. What do you actually do next? The order is subtherapeutic. What is the real-world danger here?
Right, why not just give it?
If you just blindly administer this 150 milligrams, you are giving the bacteria enough of the antibiotic to irritate them, but not enough to eradicate them. The infection will persist, the child will continue to suffer and potentially develop kidney damage. And worse, you risk contributing to global antibiotic resistance by exposing the surviving bacteria to a weak concentration of the drug, allowing them to mutate into a superbug.
That's a huge deal.
As the registered nurse, you must flag this order as subtherapeutic. You absolutely do not administer the medication. You halt the process, contact the healthcare provider who wrote the order, present your independent math clearly, and request a revised order that falls securely within the 200 milligram to 250 milligram daily safe range.
That is true clinical advocacy. You are protecting the patient and public health by knowing your math. Now let's swing the pendulum violently the other way to scenario 2, the overdose danger. This one is genuinely scary. We have a heavier patient, a child weighing 68.2 pounds. First step, instantly, reflexively, before we do anything else, we have to convert those pounds to kilograms.
We take 68.2 and divide it by 2.2.
Which gives us exactly 31 kilograms. The clinical condition is severe. It's meningitis, a massive life-threatening infection of the membranes surrounding the brain and spinal cord. The doctor's order reads ampicillin 3.375G, IV Q6H.
Let's immediately note the unit of measurement the doctor used grams, 3.375G. To make our math consistent, safe, and comparable to the Lexicomp data, which is almost always in milligrams, we should convert that to milligrams right away. Since we know 1 gram equals 1,000 milligrams, we multiply 3.375 by 1,000. That gives us an ordered single dose of 3,375 milligrams to be given every 6 hours. Let's consult Lexicomp for severe meningitis treatment with IV ampicillin.
What does the database say?
The database says the range is 300 to 400 milligram milligay divided every 4 to 6 hours. Crucially, at the end of the entry, it also lists a hard stop warning, maximum daily dose 12 to be.
Okay, this is a deep dive into the math, so let's go. Let's figure out what the doctor is actually asking us to pump into this child over the whole day. The order is 3,375 milligrams every 6 hours. 24 hours divided by 6 hours means 4 doses in a day. So we take 3,375 milligrams and multiply by 4. That equals 13,500 milligrams per day. Or if we convert it back to grams by dividing by 1,000, it is 13.5 grams per day.
Now, let's calculate our customized weight-based safe ranges for this specific 31 kilogram child to build our safety net. The minimum floor is 300 milligrams multiplied by 31 kilograms, which equals 9,300 milligrams per day. The maximum ceiling is 400 milligrams multiplied by 31 kilograms, which equals 12,400 milligrams per day. Our safe weight-based range is 9,300 milligrams to 12,400 milligrams.
Right. And the doctor ordered 13,500 milligrams, so it's already a toxic overdose based purely on the child's weight. 13,500 is significantly higher than our ceiling of 12,400. We would stop right there and call the doctor.
Correct, we would stop. But what is truly alarming about the scenario, and why it is a fantastic test question, is that it represents a double failure.
A double failure.
Not only does the physician's order of 13.5 grams exceed the maximum weight-based range of 12.4 grams, but look back at that final lexicomp warning. It completely blows past the hard, absolute maximum daily limit set by the manufacturer, which is 12 grams per day for any patient of any size. Even if this child weighed 80 kilograms, you cannot safely exceed 12 grams of ampicillin in a single 24-hour period without risking severe neurotoxicity or renal failure. This order is profoundly, doubly unsafe.
That perfectly highlights why you have to check both the weight-based maximum and the absolute drug maximum, which leads us perfectly into scenario 3, the maximum limit illusion. This is a very tricky psychological concept that I can absolutely see showing up as a trap on your exam in room 229. We have a tiny, fragile, 1-month-old baby weighing just 4 kilograms. The diagnosis is a moderate infection. The doctor's order is 150 milligram ampicillin PO Q6S. So 150 milligrams by mouth every 6 hours.
Let's calculate the total daily ordered amount first. 150 milligrams given every 6 hours means 4 doses a day. 150 multiplied by 4 equals 600 milligrams per day. That is what the doctor wants to give. Now we check lexicon for mild to moderate infections. It states the range is 50 to 100 milligrams per day divided every 6 hours. And it includes this parenthetical note at the end, maximum 2 grams per day.
Okay, I'm going to build my safety net for this 4-kilogram baby. The minimum safe dose is 50 milligrams multiplied by our 4-kilogram baby, which is 200 milligrams per day. The maximum safe weight-based dose is 100 milligrams multiplied by our 4-kilogram baby, which is 400 milligrams per day. My customized safe range is 200 milligrams to 400 milligrams per day, but the doctor ordered 600 milligrams per day.
Here is exactly where the illusion traps hurried nurses and stressed students. Imagine you are in that exam room or on the floor. You look at the order of 600 milligrams. Then you quickly glance at lexicomp, and your eyes jump to that parenthetical note. Maximum 2 grams per day. 2 grams is 2,000 milligrams. A hurried brain thinks, well, the doctor ordered 600 milligrams. The book says the maximum is 2,000 milligrams. 600 is way less than 2,000, so it must be completely fine.
Right.
But this highlights a critical life-saving lesson about how to read pharmacology texts. The 2-gram limit is a universal absolute ceiling for the drug itself, not a target or an allowance for this specific patient.
The best way I can visualize this is using a house analogy. Think of that 2-gram absolute maximum as the ultimate weatherproof roof of the entire hospital building. But your specific weight-based calculation, that 400 milligram limit, is the ceiling of the specific tiny room your 4-kilogram baby is currently lying in. You cannot break through the ceiling of their specific room just because the main roof of the building is much higher. If you give 600 milligrams, you have smashed right through their personal 400 milligram ceiling, even though you are under the 2,000 milligram roof.
That is a brilliant analogy. Even though the ordered 600 milligrams is well below the lexicomp maximum of 2,000 milligrams, it is a massive 50% overdose for this specific 4-kilogram child, whose personal biological maximum is only 400 milligrams. So the order of 600 milligrams per day or 150 milligrams per dose is absolutely not safe. You must call the physician and explain that while they are under the absolute drug max, they are over the weight-based max. The text emphasizes this strongly maximum dose does not mean that dose is safe for every child. It still must be proven safe within the range for their specific weight.
I love that house analogy. It makes it so clear. Okay, let's take a deep breath. We have covered the foundational math, the syntax, and the critical error catching. We are now moving into Section 4, the outline, specialized pediatric care. This section introduces us to passport drugs and cardiac babies. This is where the clinical complexity and the nuance really dial up. We are introduced to a baby who has a ventricular septal defect, or a VSD. This means there is literally a physical hole in the wall separating the 2 lower pumping chambers of the baby's heart.
It's a very serious condition.
Because of this hole, the heart pumps inefficiently, fluid backs up into the lungs, and these babies often struggle with congestive heart failure. To manage that dangerous fluid buildup, the baby is prescribed Lasix, a very powerful diuretic that forces the kidneys to excrete water. The baby weighs exactly 6.61 kilograms. The physician's order is Lasix 7 milligrams PO every 12 hours.
Let's establish what that order means for the whole day. 7 milligrams given every 12 hours equals 2 doses, so a total of 14 milligrams per day. Now we consult Lexicomp under the specific indication for edema diuresis. It states that for intermittent acute dosing, the initial dose is 2 micrograms as a single dose. It then goes on to say that if that first dose is ineffective at clearing the fluid, you may increase the dose in increments up to a maximum dose, 6 milligiga dose. Notice a crucial shift in language here. Lexicomp is giving us the safe range per dose, not per day.
Right, that is a subtle but massive difference. We have to adjust our math to look solely at the single administration, not the 24-hour total. Let's find the absolute maximum single dose this 6.61 kilogram baby can handle at one time. The maximum is 6 milligrams per kilogram. So we multiply 6 milligrams by 6.61 kilograms. That gives us 39.66 milligrams. That is the highest single dose of Lasix this child could theoretically safely receive at 8:00 a.m.
And what did the doctor actually order for a single dose? 7 milligrams. Therefore, we evaluate, is he ordered 7 milligrams less than or equal to the calculated maximum single dose of 39.66 milligrams? Yes, 7 is vastly below 39.66. Furthermore, even if we look at the total daily dose of 14 milligrams, it doesn't even approach the maximum limit for a single administration. The order is demonstrably safe to give.
Okay, that was straightforward enough. But then we look at the second medication ordered for this exact same VSD baby, and things get incredibly nuanced. The drug is captopril, which is a medication that relaxes blood vessels to help reduce the workload on that struggling heart. The order is captopril 6 milligram pull every 12 hours. So that is 12 milligrams total for the day.
When we look up captopril for heart failure in Lexicomp, we encounter a very specific, stark clinical warning. It says, initiate therapy at lower end of range and titrate upward to prevent symptomatic hypotension. Hypotension means dangerously low blood pressure. Think of the baby's circulatory system like a pressurized plumbing network. If you give a massive dose of captopril all at once, you open all the pipes to maximum width instantly. The blood pressure drops to near zero. The baby will go into shock, turn pale, and their organs will fail from lack of perfusion. Therefore, Lexicomp dictates that the initial starting dose for an infant is a tiny 0.1 to 0.3 milli dose. The reported absolute maximum daily dose is 6 milli dose.
Let's look at those initial safe starting dose numbers because they are minuscule. If the initial dose is 0.1 to 0.3 milligrams per kilogram, for our 6.61 kilogram baby, the math is 6.61 multiplied by 0.1 equals 0.66 milligrams, and 6.61 multiplied by 0.3 equals 1.98 milligrams. So on day 1 of treatment, this baby should only be getting between roughly half a milligram and 2 milligrams per dose. But I am looking at today's order, and the doctor ordered 6 milligrams per dose. At first glance, based on everything we've learned, that looks like a massive, terrifying error compared to the initial starting range. It's triple the starting maximum. I would want to halt the order.
Your instinct to halt is good, but this is where reading the chart and understanding the clinical context is everything. The key phrase in the Lexicomp warning is titrate upward. Titrating is like slowly turning the faucet handle to gradually increase the pipe width, allowing the body to adjust. This baby did not start at 6 milligrams today. If you look back in their chart, a week ago, they probably started down in that tiny 1 milligram range. Over days or weeks, the medical team slowly increased or titrated the dose in tiny increments as the baby's body adapted, constantly monitoring their blood pressure every hour to ensure they didn't crash. To determine if today's current 6 milligram dose is safe, we cannot use the initial starting range anymore. We must look at the absolute maximum daily dose allowed to see if the titration has gone too far.
Okay, let's find that hard ceiling to see if the titration is safe. Lexicomp says the maximum daily dose is 6 milligrams per kilogram per day. We multiply 6 milligrams by the baby's weight of 6.61 kilograms. That equals 39.66 milligrams per day.
Exactly. The absolute maximum amount of captopril this child can have in a 24-hour period is 39.66 milligrams. The current order is 6 milligrams every 12 hours, which equals a total of 12 milligrams per day. Because 12 milligrams a day is well under the maximum daily limit of 39.66 milligrams a day, and because we know from the chart that the child has been safely titrated up to this point without crashing, the order is indeed safe. It requires a much deeper level of analysis and chart reviewing than just plugging today's numbers into a minimum-maximum formula.
That is fascinating. You have to know the historical story of the patient's treatment, not just the snapshot of today's order. Here is where it gets really interesting, though. We are moving to Section 5 of the syllabus alchemy at the bedside, reconstitution and IV administration. We have spent all our time talking about liquid meds and bottles and oral pills, but many critical drugs, especially powerful IV antibiotics, don't come as liquids. They come from the pharmacy as a dry, crusty powder sitting at the bottom of a glass vial. You, the nurse, have to essentially perform high-stakes chemistry at the bedside to turn that powder into a safe injectable liquid.
And the rules surrounding this reconstitution are exceedingly strict. You cannot just guess how much fluid to squirt into the vial until it looks mixed. You must use a formal, legally binding reconstitution guide. In the Saskatchewan Health Authority, or SHA, the required document is the SK SMART Pump Program Parenteral Manual. Specifically, you must ensure you are consulting the pediatric section, not the adult section. When reconstituting, the first thing you have to determine is the precise diluent to use. Usually it is either sterile normal saline or sterile water. Notice the word sterile. It absolutely must be strictly sterile to prevent introducing lethal bacterial infections directly into a patient's bloodstream via their affairs.
Let's walk through the exact example provided in your text because I want to visualize the physical friction of doing this. The order is ampicillin 250 milligram IV Q12 hours, so 250 milligrams intravenously every 12 hours. You walk into the medroom, you open the drawer, and you pull out a small glass vial of ampicillin powder. It's from a specific manufacturer, the Orapharma brand. You boot up the computer and open the SK Smart Pump Manual. It gives you very precise, non-negotiable instructions. What does this actually look like to perform?
Step 1, you clean the top of the vial. The manual dictates you must add exactly 2.4 milliliters of sterile water to that 250 milligram vial of Orapharma ampicillin powder. Not 2 milliliters because it's easier to measure, not 3 milliliters, exactly 2.4 milliliters. You drop 2.4 milliliters of sterile water into a syringe, inject it through the rubber stopper into the powder, and gently roll the vial in your hands to mix it. You do not shake it violently or it will foam up and become unusable. Once the powder dissolves, you have created a liquid solution. But what is the mathematical strength of that solution you just created? The manual informs us that by adding exactly 2.4 milliliters of diluent to this specific volume of powder, it yields a final concentration of exactly 100 milligrams per milliliter.
Which is perfect because the manual also states that the acceptable concentration range for safe peripheral IV administration of this drug in pediatric veins is between 100 and 125 milligrams per milliliter. If it's too concentrated, it will physically burn the inside of the child's vein. Our 100 milligml concentration fits perfectly safely at the bottom of that range. Now, we need a 250 milligram dose for the patient. Since our new concentration is 100 milligrams per milliliter, how much volume do we physically draw out of the vial? Desired over half. 250 divided by 100 is 2.5. We draw out 2.5 milliliters, which happens to be the entire usable volume of that reconstituted vial. The drug is now in the syringe, ready to go.
But the procedure is far from over. Safety protocols demand that you label that drawn-up syringe immediately with a red tag. If you set down an unlabeled syringe of clear liquid in a hospital room, it could be mistaken for a flush and pushed rapidly, which could kill the child. You label it. Then, before you connect it to the patient's IV tubing, you must check the chemical compatibility of your ampicillin solution with whatever IV fluid is currently running continuously into the patient's vein. If the ampicillin is incompatible with the running fluid, the two chemicals will react and physically crystallize inside the IV tubing, creating tiny shards of glass-like precipitate that will be flushed into the child's heart and lungs, creating a fatal embolism.
That is terrifying. Reconstitution really is bedside chemistry, so you verify compatibility, and then you just push the syringe in.
Absolutely not. Once compatibility is confirmed, you do not just push the drug in all at once with your thumb. The manual dictates you must attach the syringe to a mechanical medical infusion pump and program it to deliver this medication slowly over exactly 20 minutes. This slow, controlled, mechanized delivery prevents the sudden influx of the drug from shocking the patient's cardiovascular system or causing an allergic reaction to spiral out of control before you can stop it.
It really is a highly orchestrated, incredibly rigid process. Reconstitution, concentration verification, compatibility checking, and timed mechanized infusion. Which leads us seamlessly into Section 6, the flow of life fluid and nutrition calculations. Managing a child's hydration is just as critical and mathematically intensive as managing their medication. And there is a very famous, very standard formula used in almost every pediatric ward called the 4-2-1 rule for calculating maintenance fluids. This rule determines exactly how many milliliters per hour of IV fluid a child needs just to stay perfectly hydrated while lying still in a hospital bed.
The 4-2-1 rule is an elegant mathematical shortcut based on a child's baseline metabolic rate and weight. A child loses water constantly through urine, but also through insensible losses like breathing and sweating. This rule calculates exactly how much fluid is needed to replace those losses. While the prompt source text doesn't explicitly spell out the foundational layers of the rule, it gives a clear application for heavier children. Let me explain the layers conceptually. The rule dictates that for the first 10 kilograms of a child's weight, they get 4 milliliters per kilogram per hour, which is a baseline of 40 milliliters. For the next 10 kilograms, they get 2 milliliters per kilogram per hour, which adds another 20 milliliters, bringing the baseline total to 60 milliliters per hour for any child weighing exactly 20 kilograms or more. For every single kilogram above 20 kilograms, they get 1 milliliter per hour.
Okay, let's look at the exact example given in the text to see how that math plays out. We have a child who weighs 35 kilograms. The material states even if a child is more than 30 kilograms, still use the 4-2-1 rule for the body weight. Then it shows the resulting math equation. 60 milligrams plus 1 milligram by 15 kilograms equals 75 milligrams per hour. Let's unpack the logic of that equation. The 60 ml share at the beginning represents the baseline fluid required for the first 20 kilograms of the child's body weight. We know that automatically from the rule. That part is locked in.
Correct. We have accounted for 20 kilograms. Since the child weighs 35 kilograms total, we subtract the first 20 kilograms that we have already accounted for with the 60 millil. That leaves us with 15 kilograms of remaining body weight to account for. According to the final step of the rule, every kilogram over 20 gets 1 milliliter per hour. So we multiply 1 milliliter by those 15 remaining kilograms, which equals 15 milliliters per hour. We add that 15 milliliters to our locked-in baseline of 60 milliliters. 60 plus 15 equals a final continuous IV fluid rate of exactly 75 milliliters per hour. You program the IV pump to 75, and that is the exact rate required to keep a 35-kilogram child's hydration perfectly stable.
That makes perfect sense when you break down the layers. That is maintenance fluid. But what about total intake? The text introduces the concept of total fluid intake, or TFI. These orders are written strictly by the physician, and they dictate the absolute total amount of fluid, whether it's going into an IV or going into their mouth, that a baby is allowed to have in a 24-hour period. We have an example of a small 4-kilogram baby. The physician's order is written as TFI 120 ml LQ day. Let's calculate the daily total first. 4 kilograms multiplied by 120 milliliters equals 480 milliliters per day. That is their absolute total allowance.
Now, in clinical practice, you rarely just pour 480 milliliters of fluid into a baby all at once. They would vomit. You have to break it down into manageable segments. Let's take it one step further and find the hourly rate. If the baby needs 480 milliliters spread evenly over 24 hours, we divide 480 by 24, which gives us exactly 20 milliliters per hour.
Let's say this baby does not have an IV. They are taking a bottle. The nursing schedule says they are to be fed Similac formula every 3 hours around the clock. How much formula do you put in the bottle for each feed? Well, if they need 20 milliliters every single hour, and they eat every 3 hours, we just multiply 20 by 3. That equals 60 milliliters per feed. And if you are ever in doubt, if you want to double check your math, ask yourself how many feeds are in a 24-hour day if they eat every 3 hours. 24 divided by 3 is 8 feeds. 8 feeds multiplied by 60 milliliters per feed brings us right back to our perfect total of 480 milliliters per day. The math circles back on itself flawlessly.
That kind of constant double-checking, working the math forwards and backwards, is exactly the habit a truly great, safe nurse develops. Now let's return to our complex cardiac patient, the baby with the ventricular septal defect. We have a highly specialized nutrition order for this baby, often referred to as a passport order because it dictates very specific interventions. The order reads 90 milliliter of expressed breast milk, EBM, every 3 hours. If not enough EBM, supplement with Good Start 27K Kegelsers.
But here is the truly fascinating, incredibly specific part of the order. It gives a physical instruction on how to feed the baby. Feed for 10-15 minutes by bottle, then top up by NG. Let's define that. NG stands for nasogastric tube, a small, flexible tube that goes up the baby's nose, down the back of their throat, and directly into their stomach. When I first read this, I thought, why on earth would you let a baby drink from a normal bottle for exactly 15 minutes, forcibly pull it away from them, and then pump the rest of the milk through a tube down their nose? It sounds almost cruel.
It absolutely seems harsh until you fully understand the clinical rationale, which is deeply rooted in the baby's severe cardiac pathophysiology. Think of it like making a baby run a marathon while they have a heart condition. A VSD baby has a heart that is working incredibly hard, beating frantically just to pump poorly oxygenated blood through a defective chamber. Feeding from a bottle, coordinating the suck, swallow, breathe mechanism is an exhausting aerobic exercise for any infant. For a cardiac infant, it is akin to sprinting. If you let this cardiac baby bottle feed for 30 or 40 minutes to finish the full 90 millil, they will tire out completely. Worse, they will burn more calories engaging in the strenuous physical act of sucking than they actually consume from the milk itself. They will be at a net calorie deficit. Our primary overriding goal for these patients is weight gain, so they are large and strong enough to survive their eventual open heart surgery.
So it is entirely an energy conservation strategy. We let them feed orally for just 10 to 15 minutes, enough time to get some calories before they hit the wall. But that raises another question. If the goal is pure calorie retention, why do we even bother with the bottle at all? Why not just tube feed them 100% of the time from day one to save all their energy?
Because the human body is a use it or lose it system. If a baby does not use their suck reflex for weeks at a time, they will literally forget how to do it. We must promote and preserve the suck reflex for their neurological development and for their long-term feeding capability following their corrective surgery. So we let them practice. We let them oral feed for 10 to 15 minutes, and the moment their brow furrows and they start to tire, we take over. We deliver the remaining volume of that 90 milliliter feed directly into their stomach via the NG tube, ensuring they get all the crucial calories with zero physical effort. Furthermore, if the baby is having a particularly bad day and isn't tolerating oral feeds at all, the order says to deliver the entire 90 milliliter volume via an NG kangaroo pump over 30 minutes.
And speaking of the kangaroo pump, which is the brand name for the specialized enteral feeding pump used to deliver liquid nutrition directly to the stomach, we have a couple of specific pump math problems in the syllabus to solve. The text gives us two scenarios to test your skills for the exam. Scenario 1. The doctor orders you to give 30 milliliters of Good Start formula over 2 hours. Pumps are usually programmed in ml per hour, not total volume over total time. How do we figure that out? It's
Right.
simple division. 30 milliliters total divided by 2 hours equals an easy 15 milliliters per hour. You program the pump to 15, and you are done.
But the second scenario is where students often stumble because it requires a bit more conversion logic. The order is give 75 milliliter of Similac Advanced formula over 1.5 hours. You cannot always easily type 1.5 hours into older pumps, and it makes the mental math tricky. The absolute safest method is to convert everything into minutes first. 1.5 hours is equal to 90 minutes.
Right. So we take our total volume of 75 milliliters and divide it by our total time of 90 minutes. 75 divided by 90 is roughly 0.8333. That tiny number tells us exactly how many milliliters are delivered per single minute. To find the hourly rate, we just multiply that 1 minute rate by 60 minutes. So 0.8333 multiplied by 60 equals exactly 50 milliliters per hour. You set the kangaroo pump to 50 milliliter a year, and over the course of an hour and a half, it'll smoothly deliver exactly 75 milliliter.
It is crucial to be entirely comfortable with those time conversions. Moving from liquid meditation and fluid to solid food, we arrive at Section 7 of our deep dive dietary precision and carbohydrate targets. This is an area where multidisciplinary teamwork is paramount and where a lack of communication can have disastrous consequences. In the hospital ecosystem, dietitian recommendations and orders do not live on the standard physician order sheet. They are strictly documented on a separate page called the dietitian consult sheet. The nurse must know exactly where to look to find the nutritional targets.
And there is a strict, almost militant division of labor on the ward when it comes to who is actually making and delivering the food. The hospital kitchen prepares the main meals. The mealtimes are set in stone trays, arrive at 07:30 for breakfast, 11:30 for lunch, and 1600 for dinner. However, the nurses on the unit specifically noted in your text as the 4F nurses are entirely responsible for preparing and delivering all the snacks. Snack times are 4S, 1400, and 2000. It is a highly regimented schedule.
The reason for this intense regimentation becomes terrifyingly clear when we discuss diabetic patients or any patients requiring precise carbohydrate, or CHO, counting. This is a massive, stressful nursing responsibility. Before a nurse ever walks a lunch tray from the cart into a diabetic patient's room, they must physically stop in the hallway. They must pull back the cover, review the items on the tray, and cross-reference them with the dietitian consult sheet. They must physically verify that the kitchen hit the specific carbohydrate target for that specific child within a very narrow margin of error, plus or minus 5 grams of carbs per meal.
Think about that scale for a second. Plus or minus 5 grams. That is nothing. That is the difference of half a small apple or a couple of saltine crackers. The precision required is astonishing. But it's the clinical urgency behind this math that is so intense. Let's paint a picture of a common error. Let's say you verify the tray is mathematically perfect, it hits the carb target exactly, you walk into the room, cheerfully set the tray down on the table in front of the diabetic toddler, and walk out of the room to go check on your next patient. What catastrophic error did you just commit?
You committed a dangerous, potentially lethal error of assumption. The text states explicitly, in bold, never just drop the tray and assume the patient will eat. Why? Let's look at the timeline. In a pediatric diabetic setting, the patient has likely already received their subcutaneous injection of insulin 10 or 15 minutes ago, based entirely on the assumption that they are about to eat that specific amount of carbohydrates on the tray. The biological purpose of insulin is to aggressively lower blood sugar by forcing glucose into the cells. If the toddler is feeling nauseous or simply being a stubborn 2-year-old and refuses to eat the sandwich on that tray, the insulin is already actively working in their bloodstream. Without the incoming carbohydrates from the sandwich to balance the equation, the child's blood sugar will begin to plummet rapidly, leading to a state of profound, dangerous, potentially fatal hypoglycemia. They can seize or fall into a coma.
So what is the actual safe nursing protocol when dealing with a toddler in a food tray?
You do not leave the room immediately. You ensure the food provided is something the patient is actually willing to eat right then and there. You negotiate, you encourage, you barter with them. And crucially, if you have to step out, you follow up within exactly 10 minutes. You pop your head back in. If the child hasn't touched the food or threw it on the floor, you have to be ready instantly to provide what the material calls exchanges.
An exchange. Meaning an alternative source of fast-acting carbohydrates that perfectly equals the mathematical amount they were supposed to eat from the original meal. If they won't eat the bread, will they drink an equivalent amount of carbs and apple juice? Will they eat a measured amount of a popsicle? The nurse must instantly pivot, calculate the new carb load of the juice, and find a way to get those specific grams of carbohydrates physically into the child's system to satisfy the insulin that is already circulating and dropping their blood sugar. It's a delicate, high-stakes balancing act of chemistry, timing, and pediatric psychology.
Precisely. You are constantly balancing the math of the insulin against the math of the carbohydrates while navigating the unpredictable behavior of a sick child.
Okay, let's take a step back and look at what we have covered today. We have summarized an incredible, intense journey through the realities of pediatric medication math. We started with the absolute intolerance for trailing zeros. Remember the 3.00 AM optical illusion and the rigid rules for rounding volumes under and over 1 milliliter based on the physical syringes you will use. We explored the exclusivity of Lexicomp over adult databases and how to calculate precise milligram per kilo doses, finding those tight windows between the subtherapeutic floor and the toxic overdose ceiling.
We also deeply examine the critical thinking required when physician orders are flawed, whether they fall short of the minimum to cure an infection or break through absolute daily limits, causing toxicity. We discussed the nuances of passport drugs like Lasix and Captopril, where understanding the patient's long-term titration history and the metaphor of plumbing pressure is just as important as today's math. We walked through the sterile, precise alchemy of 5E reconstitution, the metabolic logic of the 4-2-1 fluid rule, the marathon running energy conservation feeding strategies for cardiac babies, and finally, the rigid, time-sensitive coordination required for diabetic carbohydrate management.
It is a lot of information. It is dense, it is heavy, and it is consequential. But remember your mission. Remember why you are listening to this deep dive. That exam on Thursday, March 5th from 0900 to 1000 in room 229 isn't just a hurdle to get your nursing degree. It isn't just about getting a good grade. It is the gateway to keeping kids safe. Every calculation you master, every trailing zero you refuse to write, every independent blind check you insist upon is a shield protecting a vulnerable life.
I would like to leave you with a final lingering thought to mull over as you pack up your notes and prepare for this exam. The next time you walk through a pediatric ward during your clinical rotations, look closely at the nurses working at the med carts. Beyond their excellent bedside manner, beyond the soft voices, the colorful scrubs, and the comforting smiles they give to terrified parents, recognize the invisible, relentless, mathematical symphony happening in their heads every single second of their shift. They are constantly calculating the precise weight of life, converting pounds to kilograms, scaling minimums and maximums, tracking half-lives, verifying chemical compatibility, and negotiating exact carbohydrate ratios. How often do we trust our lives and the lives of our children to the math of strangers without even knowing it? That unseen math is the profound, quiet heroism of pediatric nursing.
Wow, that is exactly it. The math of strangers. Thank you all for joining us on this deep dive. I hope you feel more prepared for room 229, more alert to the dangers, and more inspired by the gravity of what you are actually learning to do. Stay curious, trust your calculations, double-check your boundaries, and keep seeking out the fascinating life-saving complexities hidden in your everyday professional skills. Good luck on Thursday.